Okay, so now I'm
Yes.
starting.
Yeah, welcome everyone. And myself, Vishwat Mishra from marketing team from Lupin Oncology. And I welcome everyone here for this scientific session on treatment of HER2 positive breast cancer. As we all know, the treatment paradigms have changed over the years. And
Sir, sorry to interrupt you, but I guess you're muted, sir. Can you please unmute yourself?
okay, so
Yeah.
yeah, very good evening to everyone and the attendees. And today we are here to have a session on the treatment of HER2 positive breast cancer. As we all know, that HER2 positive breast cancer, the paradigms have changed and newer paradigms are emerging and newer treatment lines are emerging. So today we have Dr. Sudhi Kamboj, who is a consultant and head of department of breast and endocrine surgery at Nutema hospitals with considerable years of experience in imparting the services in the breast cancer and patient support. So I welcome Dr. Sudhi Kamboj for the session. Welcome, ma'am, and the dice is yours.
Thank you very much, and thanks the Lupin team for inviting me for this webinar. And it is a really important topic which we will be discussing about. Uh, I myself, Dr. Sudhi Kamboj, as was introduced, and thanks for your kind introduction. As a breast surgeon, we all know that breast is a heterogeneous disease, and it has a lot of biological diversity, especially the hormone receptor status, and the most important one is the HER2 receptors. So not all breast cancer they have the same receptors. They have biological diversity, which is because of which their treatment plan is also different. And within because of this understanding, in the last 2 decades, about 50% reduction in mortality in breast cancer happened worldwide because of our understanding of these biological diversities. So before going on further about this presentation, I would like to brief about all those participants who are here, that we will be discussing about the most practical and the basic aspect, the fundamental aspect of the treatment of the HER2-NEU breast cancer, with an emphasis on the trastuzumab, which is the most important and the breakthrough treatment in such patients, and with a discussion about some newer emerging treatment modalities as well. So we will be discussing about the very basic about what we should know about the treatment of these breast cancer patients. So what is this HER2 receptor? Basically, it is a human epidermal growth factor receptor. In short form, we name them as HER. And there are basically four type of HER receptors: 1, 2, 3, and 4. These are transmembrane receptors with transmembrane receptors with the tyrosine in the family of the tyrosine kinase, and they have an extracellular domain and the intracellular domain. And through the extracellular domain, usually they receive the signals which is transducted throughout the cell membrane, and the intracellular domain then transmit these signals to the genes, to the nucleus. And usually these signals are the growth factor growth signals, and which induce the cells for further growth. So there are basically four type of HER receptors. The most important one is the HER2 receptors, because the signals transduced through these receptors are very strong, and they transduce a very strong signal for growth promotion. Usually, whenever any signal is transmitted, these receptors they combine to each other, and they form either, if they combine with the same receptors, they form the homodimerization. If they combine with a different receptor, they form the heterodimerization. And when they combine with each other with this dimerization, this induces the signal which is further transmitted inside, and which induces the nucleus to grow. And the most powerful signal are induced with the combination of HER2 and HER3 receptors. And that is why this HER2 receptor is very important for us. The pathway, the intracellular pathway through which these signals are transmitted is the HER pathway. These are the tyrosine kinase, PI3 kinase in pathway, and this a battery of different molecules working together to transmit the signals inside the nucleus, and altogether we call them as HER pathway. These HER2 receptors, as already said, as such, they are normally present in all the cells because they are important for the growth of the cell. But in certain breast cancer cells, these receptors are overexpressed. These are proteins and these are overexpressed. And because these are growth promoters, the more they are overexpressed, the more chances of the cancer cells being aggressively growing is there. And the credit goes to Dr. Dennis Slamon and his team, who in 1980s observed this phenomena. And the team also observed that the cells who are overexpressing HER2 receptors, they are more aggressive in their behavior, they have more growth potential and the tendency to spread. These type of cells were observed in both the tumor site as well as the metastatic site. And they found that in the absence of any therapy, these cells are very, very lethal. And that is why any HER2 positive breast cancer cells were really very aggressive and with very bad prognosis. This is the HER2 receptor. It is represented as red and it has an extracellular domain and the intracellular domain. They were unique, as already said, because the signals transmitted through these receptors, they were very strong and they give a very strong signal to proliferate. Secondly, as you can see, they don't have any specific ligand. So most of any growth promoter can usually incite their activity. So as already mentioned, there are four types of receptors. Usually they heterodimerize. The most lethal one is the HER2 and the HER3 dimerization, and which activates the HER pathway and which leads to signal transduction and the nucleus proliferation. So knowing all these facts about all these proteins, various receptors, various targets were identified by the scientist where the drug can actually act to inhibit this proliferation pathway, this HER pathway. There were extracellular domains as well as there are intracellular domains. Because of paucity of time, and it is very impossible to discuss all these in detail at a particular time, we are in this session are limiting ourselves to the drugs which are acting in the extracellular domain. And maybe in future, we will try to cover all those drugs which act on the intracellular domain as well, with a main emphasis on trastuzumab because it is the landmark in the treatment of the patients with a HER2 positive breast cancer. It was detected first in 1980s and a lot of various work, various research occurred on it. Ultimately, in 2005, it was approved by FDA to start the treatment in the metastatic breast cancer setting. So what it does, it basically binds on the extracellular domain, the target 2 of the HER2 receptors, where after binding to it, how does it help? It basically, first being an antibody, it incites the antibody mediated cellular immunity. So lots of the natural killer and the other cells, they come and attack the particular cells on which this antibody is attached and thus destroy the cells. Secondly, when it attaches on the extracellular domain of the HER2 receptor, this receptor is becomes partially infunctional and this receptor gets internalized. So thus it down regulates the receptor. But the most important function is the stoppage of the signals which were transmitted through these receptors to the nucleus. And this was the main mechanism through which, and once these signals are interrupted from almost all of the HER2 receptors, the cells stop, the nucleus stop proliferating, the functioning, and ultimately the cell eventually dies. So these are the three basic mechanisms through which this antibody works. But though it was a landmark in the treatment of HER2 receptor, but HER2 positive breast cancer, but it was not easy to put it into the society to start as a regular medication beyond the one which were already in use, like the anthracyclines and other cytotoxic chemotherapies. So many questions they came up. Through this in this session we will try to answer all these one by one. So the first important question which came up was its consistent and significant benefit of adjuvant trastuzumab in addition to chemotherapy. The various trials they ran to find out the efficacy of this particular molecule in the selected patient, the HER2 positive patient, and they found that when we combined the trastuzumab in patients receiving chemotherapy, there is a significant increase in the disease-free survival of 36 to 58% in those patients compared to the controlled arm, except for one PAC-04 study was there, which did not approve this. But in that study, there were some issues with the selection of the patients, the duration of the Herceptin therapy. Otherwise, those who gave them in full, usually they reported very good outcome. The other question which arose was the optimal duration. So many studies again came up to find out to the optimum duration of this therapy. The important one being HERA trial, which in this trial the patients were randomized to give therapy for 1 year and the 2 years. So they studied the duration of her trastuzumab therapy for 1 year and 2 years, and they concluded that there is no added benefit for 2 years, and it only increases the cardiac toxicity in patients. So beyond 1 year, they did not find any added advantage. Similarly, there was another study which studied the duration of 6 months versus 1 year. So after 6 months, they randomized the patient to stop trastuzumab or to continue up to 12 months. And they concluded that despite higher incidences of cardiac event, 12-month therapy is better than 6-month therapy. The other question which came up, whether to give it in a neoadjuvant or the adjuvant setting. So anti-HER2, there was, when we searched the literature, no direct comparison was still done between whether to give adjuvant or neoadjuvant therapy, but it has been shown that in a neoadjuvant therapy, once this molecule is given, then there's an indirect evidence that there's a high pathological complete rate. So many recommend giving it in starting from the neoadjuvant setting when the biopsy report is available and we know the receptor status. If it is positive, to start from the neoadjuvant setting. So one very important question is whether to give concomitant or sequential with the chemotherapy. So this trial was very interesting and very important, in which they gave the sequential versus concurrent. They compared the sequential versus concurrent therapy, and they found that there is a strong trend for 25% reduction in the risk of an event when the trastuzumab is started concurrently with taxane, relative to when it is started sequentially after taxanes. So the thing is, it is not started with, they do not recommend starting with anthracycline because of cardiac toxicity, but once the anthracycline therapy is completed with taxane, we can very well add, and it has an added advantage. So what is the optimal chemotherapy regime, whether we should give anthracycline or not give? So this trial, they randomize the patient to 3 arms. One arm received anthracycline, cyclophosphamide, followed by taxane. Another arm received anthracycline with taxane with herceptin, and The third arm did not receive anthracycline, only carboplatin, herceptin, and taxane. So what they found that there was no significant difference in efficacy, either disease-free or overall survival between the two trastuzumab regimens. So these two trastuzumab arms were better than the anthracycline, no trastuzumab arms. So trastuzumab regimes were better in disease-free and overall survival compared to the non-trastuzumab regime. The rate of congestive cardiac failure and cardiac dysfunction was significantly higher in the group receiving anthracyclines plus trastuzumab than in the TCH group. So overall, if we see TCH, which did not have the anthracycline but has the trastuzumab, is a very good option and should be chosen when cardiac risk factor or if there is a contraindication for anthracyclines are present, because the the most important side effect, trastuzumab is a very well tolerated medicine, but the most important and the important side effect is the cardiac toxicity, the congestive heart failure and cardiac dysfunction, for which we have to remain vigilant. So this was the most limiting factor in such patient. So coming on to pertuzumab, not all patients, HER2 positive patients receiving trastuzumab, they fare well. Many a time it happens, these patients, they develop some alternative pathways of signaling, and the whole purpose of giving the trastuzumab trastuzumab is not met. So there were another the molecule was developed. It is also humanized monoclonal antibody pertuzumab. So what does it do? It binds to the target 4 of the HER2 receptor. So we can see there are two different sites. This at this site, this is target 2 where the trastuzumab binds, and this is the target 4 where the pertuzumab binds. So then how does this pertuzumab helps? It helps in inhibiting the binding or the heterodimerization of HER2 with HER3 or any other HER receptors. So once it is there, it prevents the binding or the ligation of HER2 with HER3. So the signal transduction mechanism does not initiate, and therefore the signal is not transmitted. The growth signal is not transmitted. And if this pertuzumab is not there, this area is empty, and uh, the other receptor can very well bind to this area. So the whole purpose of this Herceptin will then not be solved. So in HER2 positive breast cancer, the recommended treatment is to add pertuzumab with trastuzumab with docetaxel, and it has very dramatic results. The third important drug in this category is the TDM1. So what is this TDM1? In this, the HER2, this trastuzumab antibody is linked with thioether linker to the antibiotic. This is an antimicrotubular agent, maytansine. This is also known as DM1. So this whole molecule is known as TDM1. So then what it does, it do when this drug is given, this drug, because the Herceptin recognize its HER2 receptor and directly go to all those cells who are overexpressing those receptors. So directly it goes to the tumor cell where it binds to its target 2. From here, it is internalized and it is sent to the lysosomes where the outer body is defragmented and this antibody is released, from where it goes into the microtubules and there it inhibits the microtubule formation. So this is how it helps in the destruction of the cell, because it then inhibit the important process, the microtubule formation of a particular cell, the cancer cells. And because it is a very specific targeted therapy, most of these therapies, they don't have any major side effects, and these medicines are very well tolerated. And second advantage is that they act directly on the tumor cells in a higher concentration, so they have a dramatic effect on the tumor. So when this therapy is given, it is observed that the tumor shrinkage is significantly better. It is in fact 400, reported to be 400 times more potent than trastuzumab alone, because in a single molecule of trastuzumab, around 4 to 10 molecules of the antibodies are attached. So the various available regimes of HER2 positive or recurrent metastatic breast cancer is the preferred regime is pertuzumab with trastuzumab with taxanes, and the other recommended regimes are adotrastuzumab, that is TDM1, trastuzumab deruxtecan, TDXD, trastuzumab with chemotherapy, and trastuzumab with lapatinib. So if we conclude our talk, since the approval of trastuzumab in metastatic setting, the clinical landscape of HER2 positive cancer is forever altered. The HER2 positive breast cancer has now become a chronic and manageable disease with meaningful response and a clinical stability. In less than a decade, because of it such a good efficacy, it is now approved for adjuvant treatment also. And the trastuzumab is now essentially recommended for all patients with early stage HER2 positive disease, with the exception of those with very small node negative tumors or those with a significant comorbidities and at increased risk of cardiac complications. Trastuzumab refractory cases problem is a problem, especially in CNS metastasis where the penetration of trastuzumab is not good. There, the role of new drugs like lapatinib, pertuzumab, and adotrastuzumab in the neoadjuvant and adjuvant setting as a single and dual HER2 targeted strategies with or without chemotherapy have shown a promising result. But in India, obviously, the cost is a limiting factor. And with this, I would like to thank you all for your patient hearing. Your suggestions, opinions, and your comments are invited.
Dear delegates, if you have any question and queries, then you can put in the chat, or else you can unmute yourself and directly ask.
Thanks, madam. I think as of now, there are no further questions. So I would like to thank formally Dr. Sudhi Kamboj for taking a wonderful session with sharing the insights on the management of HER2 positive breast cancer. Thanks, madam. Thanks for time given and thanks for sharing the insights.
Thank you very much.